Hello, I'm Adam Bress, Associate Professor of Population Health Sciences at the University of Utah School of Medicine and Chair of the upcoming AHA Scientific Statement on the Management of Elevated Blood Pressure in the Acute Care Setting.
And I'm Tara Chang, Professor of Medicine at Stanford University and co-chair of the upcoming statement. What do you think led the AHA to decide to commission this statement?
Elevated blood pressure in hospitalized patients is very common, and while there's a large body of evidence for managing high blood pressure in the outpatient setting, there's very little high-quality evidence and almost no randomized evidence to guide blood pressure management in the acute care setting. If there is a true hypertensive emergency, where there's not only very high blood pressure readings but also evidence of new or worsening target organ damage, there's no question that that needs to be treated promptly. But what to do about asymptomatic blood pressure elevations in the hospital is much less clear, especially since recent observational studies have shown potential harms associated with aggressive treatment in these situations, which we'll talk more about later.
Asymptomatic elevated inpatient blood pressure is much more common than hypertensive emergencies and can actually affect upwards of 50 to 72% of hospitalizations. And though we lack good data to guide us, treatment with antihypertensive medications in these cases is really common. And the reasons for treating asymptomatic elevated inpatient blood pressures vary, but emotive terms like hypertensive crisis and hypertensive urgency could contribute. Health system factors also contribute, including responses to vital sign alarms, clinical decision alerts, and nursing notifications.
That's one of the reasons why we propose changing the terminology in the statement. For example, for a hypertensive emergency, we mean blood pressure greater than 180 systolic or 110 to 120 diastolic with evidence of new or worsening target organ damage. That's unchanged, since, as you mentioned, this term is important because it indicates a need for urgent action. However, in the much more common scenario where there is no evidence of new target organ damage, we introduce new terms: asymptomatic markedly elevated inpatient blood pressure. This is for pressures above 180 systolic or 110 to 120 diastolic, and then also asymptomatic elevated inpatient blood pressure for readings that are above 130 over 80. We felt that these more neutral terms that remove the emotive language of crisis and urgency, which may promote unnecessary interventions.
It's also important to note that certain demographics are at higher risk for having asymptomatic inpatient blood pressure elevation, including older individuals, Black adults, and those with comorbidities such as diabetes, chronic kidney disease, and cardiovascular disease. Individuals who are socioeconomically disadvantaged, underinsured, or living in low-income areas are also at increased risk. Additionally, those who are non-adherent to antihypertensive medications are more likely to be hospitalized for hypertension-related issues.
These insights really do underscore the need for targeted interventions and perhaps more individualized strategies for populations that not only manage the underlying condition but also address the broader social determinants of health that really do substantially contribute to these risks.